today is not an event about what health AI could do. It's about what it takes to make it work. The engineering constraints, the science, the clinical reality, the gaps. So we'll start with a fireside and then move to a panel. It's my pleasure to welcome Martin, co-CEO of R37 at R1, a brilliant clinician, scientist, founder, and all-around nice guy, I'd like to say. And how about this for a teaser? He left DeepMind to work on billing codes. Let's dig into why that's a technical challenge worth chewing on. Martin.
Hey guys, yeah. I made a huge mistake, huh?
Well, you convinced me it was exciting, which is hard to do. I really said I'm never going to touch RCM, but meeting you made me reconsider that. So I'm excited for this conversation. You co-founded Fair Health as an AI native healthcare intelligence startup. R1 acquired the company, and now you're running the innovation lab from inside one of the biggest RCM incumbents in healthcare. What do you think about that? How's that going?
Yeah, to me, like, I'll give a little bit of my background, how I came to be in the sexy space of medical coding and billing. So I have a funny accent. I'm from Australia. I started, like some in the room, like, respect to be in scrubs. I started in as a doctor. I did my medical training in Australia. I did my basic residency there. And then, classic story, I got like frustrated with the software systems we're using, all the data we're not using, and have been on a winding journey into the world of digital health more broadly, and then, you know, into the actually surprisingly exciting world of revenue cycle management. That pathway, you know, I worked for a bit at a startup in Australia. Then I came to Stanford to do this biomedical informatics training program. Then I joined DeepMind and moved to the UK and was there for a few years working on sort of clinical language modeling. Initially in a sort of research-oriented team. I see a Googler there right in front of me. And, you know, at Google, the frustration really was like, it's hard to get this research into anything real for healthcare. I say that with the greatest love for Google, but like it was hard, even with the resources of a big tech company, to get things into production. And so we left and co-founded with you know, a colleague from DeepMind, a colleague from the Stanford program, a company called Fair Health. We were split between New York and London from the very beginning, and we tried to tackle this problem of inpatient coding, which is one of the slivers of healthcare finances that is actually quite global. Like every country, most mature health systems around the world will against same global standards. Like ICD that we're familiar with is actually put out by the WHO. It's an international standard. And all over the world, you know, they've gone through this digital maturity curve and now coming to kind of reckon with, like, how do we deal with healthcare finances and this problem of allocating resources across the healthcare system. So that's what initially brought me to revenue cycle. And actually, inpatient coding is in some ways the oldest problem in the book. I think the first paper on inpatient coding was published like 50 years ago, but it is still surprisingly an unsolved problem. And it's one of those classic, like, jagged edge phenomena of AI where, you know, Claude can do amazing things, but when you have a, like, correct answer and you have this, like, big multi-label, multi-class classification problem where there's a right answer, like, it's not that good. It's really bad still at a problem like inpatient coding. So we started working on that. We scaled up the company through the US, in the US market, and eventually started to work with R1. And there, sorry, this has been a really rambling, like, first answer. What was the original question? Anyway, we started to work with R1. It has been an interesting journey so far. And I can go a little bit into
The details there. Let me pause.
You about some specific details. So a few things there first. So you mentioned that it's a genuinely hard engineering problem. And even when you had the resources of Google behind you, you still weren't able to tackle them. And so you wanted to go within the healthcare system directly. And now that you're in healthcare, but it's a legacy system, there's like two different sets of problems. So you mentioned, for one, that this is a genuinely hard and interesting engineering problem, and one that, you've been digging your teeth into. What makes AI in this environment difficult? Like, what makes you keep thinking about it, keeps your wheels turning every day, that makes you want to stay here?
It is still a technical and scientific challenge to get something to work for real with all of the edge cases of healthcare, right? And so I'm kind of tickled by that challenge. And then also, I started in medicine. I came to this world. Ultimately, I want to change healthcare. As far as trite as that might sound, and I don't think AI still really has done that over the years. I think 6 years ago, when I was still at Stanford, I published this paper, Bridging the Implementation Gap of Machine Learning in Healthcare, which was sort of bemoaning how we publish a lot of papers, they go to the model graveyard, nothing ever happens. I think that is still largely true. And so I think that still sort of motivates me. I want to kind of get something into the real world.
And now that you're within healthcare, so health tech is an interesting place, and even this room, I'm curious, I wasn't planning this, but how many of you started from the healthcare side of health technology? So that's about a third. And how many of you got here from the technology side? So it's an interesting mix. We come here from different places, and it's an intersection. You've tried it from technology, and now you're trying it from healthcare. How did this legacy organization, has it resisted change, and was it more ready than you expected to try things differently? I think it's an interesting moment that legacy infrastructure may no longer be the barrier. It's never been easier to start over. And what's that been like from the inside?
Yeah. The reason we joined this company was basically, so there are two elements. One, from a very tactical perspective, the biggest limitations for health AI companies, I think, are data and distribution, really, right? And I do believe it's not the only way, but a very effective way to make impact is to partner an AI native company with an organization with data and distribution. Secondly, I think in the RCM space in particular, and I say this kind of as an outsider looking into US revenue cycle management, it is a broken Frankenstein of a process. Like we all know, it should be changed, it should be shaken up. But in order to collapse the process, you need a certain level of scale. And the reality is, in a lot of the startup ecosystem, FAIR was like this as well. You're just forced to go deep on one narrow problem. But for this particular industry, I think the unlock is platforming, collapsing a number of these traditionally point solutions into one thing. And what that looks like for healthcare claims is essentially something that resembles real-time adjudication, where a claim is immediately, adjudicated, swiping credit card, rather than this whole labyrinth of processes in between. And so that was a very appealing sort of prospect of really budding up, and that is kind of coming true. We are now this hybrid organization of an AI lab within a legacy company, and we're trying to leverage all of the unfair advantages of that data, subject matter expertise, install base, et cetera, to really change how healthcare claims work.
And so when you're innovating within a large company, so I used to be at CVS before I decided to, be crazy and work for myself. But within CVS, there are different teams, and I'm sure it's similar at RCM, those who are technology forward and those on the business stakeholder side. And to be able to succeed on the technology side, which is typically seen as a cost center, it needs to be valuable for the business. And How are you building this lab within there to create that value for the business? How are you bringing AI to be front and center to the identity of this legacy company?
Yeah. That's our mission. And, a little plug, a reason we're recruiting as well. Like, join us on this mission. We're at the beginning of that process. But what I will say is it's real, and the intention is really there. I think, I sometimes imagine the situation at R1 as just one humongous hospital back office, because that's kind of what it is. Like, it's plugged, R1 and works with 95 of the top 100 health systems. It's sort of an invisible presence behind the scenes of a lot of healthcare, submitting just this huge number of claims manually. So there are like tens of thousands of people internally within R1 who are doing these antiquated billing processes. And so that is just a really unique situation where in-house we have these people who are the customers of this, whose workflow and everything we need to change. And we all know how difficult it is to change really ossified healthcare workflows when you're working with a partner, but it's a bit different when you're working internally with people. And so I think that's another factor. Like, it's actually working quite well because the consumer of this is internal, and the innovation is not just like a technology that we're forcing down the throat of a healthcare operator. It's like an innovation in the workflow as well as the technology that goes with it. Yeah.
And I think that's definitely an asset, because sometimes on the product side, it's incredibly challenging to get access to your healthcare customers when you want to do usability testing, when you want to reach out to them. So being able to do that in real time definitely makes it faster to deliver the right products. So can you walk us through what AI looks like in production at R1 right now? So not what you're planning, but what you're already running, what you're already touching, and where it helps the most, and where is it making the biggest difference?
Yeah, so revenue cycle, for anyone who's familiar with it, is like quite bonkers in how it works today, right? Like, there are, on the provider side, a dozen different processes, from pre-registration and scheduling and coding and billing and auditing and CDI and, probably 20 processes. And then there is a mirror image of processes on the payer side. And all of those things are required to get a claim paid. At R1, we essentially, are like a mega hospital on the provider side. So we have thousands, sometimes tens of thousands of people doing these tasks, and they are today using AI AI is doing a section of their work, or it's supporting them to accelerate how they're doing that. And so you could pick any user persona along that life cycle. Let's take a medical biller whose job today is to kind of look at the EHR, look at some separate admin billing system, try and figure out why a claim has been denied, try and attach new information, Like, that process today is being run with the support of AI or entirely in an automated way within R1. And that is just the beginning. There are dozens of these kinds of processes through RCM to really collapse it.
What problems haven't you solved yet that you're excited to do next?
The problem we started with, inpatient coding, is still not solved. Like, it's actually still it's a scientific challenge to get to the level of human or superhuman accuracy on inpatient coding. So we have a research team focusing on problems like that. There are other problems that are solved from a accuracy perspective, but are not solved from a deployment perspective, where, you just need to change a workflow that's existed for a long period of time, et cetera, et cetera. So, the end goal of collapsing revenue cycle from 20 processes into one, and going from it taking 90 days to get paid for a claim to it taking 90 seconds, there's a lot of work to do. That's why we're recruiting. And that's going to be a multi-year mission. But I would say we're at the stage where we are, for real, seeing AI deployed in healthcare workflows with real live clinical data at scale, and seeing the the positive impacts of that. And now it's a question of scaling that up.
That's great. And so within building this R&D function within this large enterprise, how are you keeping that connected to what actually ships? And you mentioned that you're framing it as a lab, which could just be on the research side and being on the cutting edge, which is, I think, is also an interesting point of view. So how are you balancing keeping up with the latest in AI? And I'm going to ask the panelists this question later in a similar way, but I'm curious how you're thinking about it versus actually shipping things forward and iterating and learning.
Yeah, I mean, we're very outcome driven, like, and we're forced to be because we have tens of thousands of people internally within the company who are doing these things, who are crying out for, like, I can't get through my workload, or I need to do things differently. And so, Google, it was a bit different. We tried to, kind of release a product into the ether and hope that it would be used by a billion people. And like here, it's just very direct. We have these people on our team who are doing these things, and like we track all of their metrics around speed and throughput and all of that stuff. And so I think that just forces us to be very, applied in how we do things. And so, we're not, as a result, like we're a lab in a sense, but we are not precious about like just pushing forward the scientific frontier. Like where an existing method can work fine, and there are plenty of places, great, like let's diffuse that quickly and get the impact. There are other problems where the methods today don't work well, and we need to do some research, and it's a longer horizon to impact. And so that's generally our approach. We're very outcome orientated.
And to that point of doing more research and being excited about what's coming next, I like asking founders or leaders the question of what keeps you up at night. But what's funny is most founders answer that in the negative, what they're scared of and their challenges. But what keeps you up at night because you're so excited about it and you like can't wait to work on it?
My 2.5-year-old toddler keeps me up at night. I don't know. I mean, this feels like an inevitability in the case of RCM, right? Like there are certain things in how AI will change our world that are still a question mark. But like, I think no one would disagree that like this crazy antiquated process of healthcare claims like will definitely look different in 5 years' time. And so I'm like in a rush to get there, because I think honestly, like, we have every ingredient to do that, and I will feel guilty for the rest of my life if we don't do that. So, or at least like contribute meaningfully to doing that. And so I have this like, recurring dream about like dropping the ball on this, because like we actually can do this for real. And if we don't, it's because I've screwed up.
What an epic North Star. And I'll ask you the question. If people noticed when you walked in, we had a question on the whiteboard. We're curious what you all have to think about this as well. But what is everyone thinking about health AI, but no one's talking about? What's the piece that no one's saying out loud right now?
I don't know. This is just the thing that comes top to mind, but I do find in a lay audience, let's say, when you talk about AI, there is this assumption that it's continuously learning. And that's like, for the most part, not true, right? Like you are like actually getting that feedback loop is pretty hard to do in an efficient, like systematized way. And so there's this general sense that AI is just like forever getting better. And I think people then just are surprised when it doesn't. It's like, it's pretty hard to do that kind of stuff. Yeah. That's just one of several.
I think it's a great thought, because we're going to talk a little bit about that on the panel. So it's as if I wish I had planted that, but you said it better than I did. So thank you. Let's do a round of applause. And we have couple minutes, maybe max 3 questions. If anyone has burning questions, okay, so he was so fast, that was burning. You could ask that question before we switch to the panel.
Thanks. So I remember back when we went from ICD-9s to ICD-10s, you had to get ready if anyone's working on digital health in the mid-2010s. Now we're looking at Medicare insolvency, circa 2032, 2033. We're going to have Social Security insolvency, around the same time. Those are both about 25% cut I've seen on analyses. So are you all thinking about that sort of as an upgrade to what you have to do? Because I don't think many people are thinking about that yet, but is there sort of an ICD-9 to ICD-10 move you have to make in terms of RCM?
Yeah. So
A few components. So there was sort of the ICD 9, 10, 11, like big kind of tectonic changes in kind of the RCM space. How do you manage that? And then also this like an issue of CMS insolvency that's impending in the early 2030s, and how that's affecting the industry. And so, yeah, I mean, it's a great and big question. Like in the case of ICDs, I'll take that like maybe slightly easier one first. Like we're today in ICD 10, but ICD 11 has already been out for a while and is like going to, increase the sort of number of codes, for instance, by a factor of about 5, 4-5. And that is something the industry will have to reckon with. It is still, I think, like a bit crazy that the WHO publishes these things, and then like 5 years later, like each country sort of adopts them, and then it takes 5 years to adopt, and like by definition, you're 10 years behind in all of these things. But I do think the current technologies will make the transition easier. Could speak more about that. CMS insolvency, I mean, yes, that's like a really problematic issue in this country. Like one of the fabric of public healthcare funding is being challenged. And we're seeing as a result, like a lot of regulatory changes in how CMS is working. Like that, we've seen that recently with prior auth changes, for instance. I think the reality is we're going to have to see some deflationary force in RCM in order to make this work, right? Like, and I think that the compression of the steps in this process can lead to some level of deflation.
Thank you. And thank you for being willing to take a question. I'm going to keep us moving. You could chat with Martin after, because I do want to be respectful of your time. I know it's not great to sit forever. You want to talk to each other. So I'm going to move on to the panel. Thank you, Martin.
no worries. Thank you for having me.